I'm just going to go over a couple things, just mainly one main case that I saw that just wanted to present and talk about, just because it's a frequent thing that we get of someone coming in with a hand mass or some growth of some kind on their hand. And we thought we'd talk about it and show some cool pictures and just kind of review some things. So this is a 52-year-old female who came in for wrist pain. It's been going on for about 3 months. Had this swelling kind of on the volar aspect of her hand, or by her thenar eminence. Worse over the past 6 weeks. The mass has been growing, and it's harder to do things that she likes to do. It's hard to do push-ups. She likes to do yoga. Mostly when she's at the grocery store, she finds herself hiding her hands. She's tired of doing that. What questions do you have for her? What concerns do you have? What thoughts come in your mind as you see this mass?
Has she ever had any similar things on the same wrist or opposite wrist before?
Great question. No, she's never had anything like this. It freaks her out. She's nervous.
I want to see kind of like density of it. Is it a hard mass? Is it
Great.
synovial fluid kind of? Are we talking joint, or is there a bone growth?
Yeah. What are some ways you could determine that?
X-ray.
X-ray. Okay. What would you be looking on X-ray that you potentially could see?
Something big and white versus fluid filled.
Good. If it's fluid filled, what will you see on X-ray? Nothing, right? Right. Versus if like a chondrocalcinosis, right, where you have that calcium buildup, right? Good.
At the best, is it movable?
Yep.
I wrote
Is
to ask that
it
question.
movable? Okay. Yep. Palpating it.
Yeah.
Okay. What's as you see this? What's your differential? What's kind of coming up to your mind? What's the most common stuff that comes up in the hand, and what's most likely? What's not likely, but still should always be on your radar?
Ganglion cyst.
Okay. Ganglion cyst. Most common mass in the hand, about 59 to 65% in the hand. What's a ganglion cyst? I'll give you a different word. Maybe you'll connect the dots. What's a Baker's cyst?
The fluid-filled mass, sometimes synovial fluid. I don't know if ganglion is synovial, but it probably is. Since you're shaking your head, yes.
You're
I'm trying to
smart.
think of the last time I drained one and analyzed it. No, I haven't.
Yeah. So it's the same thing as a Baker's cyst. A Baker's cyst is just some guy's description of a ganglion cyst in the knee, and he just wanted to slap his name on it. Okay. Next one that you worry about, or is not worry about, but is common, is a lipoma. That's another one. So basically just a benign growth of fat in the area of the wrist. The key thing that we'll talk about today is the location. So lipomas are going to be in areas of the wrist where there's more fat. On the volar aspect of the wrist, is there a bunch of fat there? No, right? So that's more on the dorsal aspect or on the radial aspect, on the dorsal side. Okay. Any other differentials? Things you worry about in the hand? What if this was on the palm? Anyone know what that would be? We're stretching your mind today. This isn't the back. Okay. It's called an epidermal inclusion cyst. Have you guys ever heard of those? So basically, if you have a big mass on the palm or the finger, big growth, usually what ends up happening, you've had a puncture wound. The puncture will push in epithelioid cells. It'll get turned in and invaginated. But guess what? Epithelial, no matter where they are, will still grow. So they grow inside and create a cyst. So it's called an epidermal inclusion cyst. So that's going to be back to that question of the ladies. Hey, any trauma to this area? And if they said something like, "Oh yeah, I had a cardiac catheterization about, I don't know, 6 weeks ago or 6 months ago," what would you worry about there? What does that have to do with the hand? What?
Aneurysm.
Yeah, pseudoaneurysm, right? So you've punctured a hole in the artery. That hole didn't really do a good job of kind of healing up, and it created this pouch. Okay, that's that dermal inclusion cyst. Oh, giant cell tumor tendon sheath, 43 per million. So it's not super common, but it's there. Giant cell tumor tendon sheath is basically, it's ganglion cyst like, but it's more a different, it's not synovial derived, it's derived from giant cells that grow in from the tendon sheath. It's really not anything scary. It sounds horrible because it's a tumor, people freak out about it, but it's honestly not too significant. Glomus tumors, which are just tumors in the fat that's more on the fingers, so it's not as common here. But the key thing we always want to keep in the back of our mind with hands is there are some pretty scary stuff that can be in the hand. So not just looking at a mass and saying it's a ganglion cell, right, or a ganglion cyst, but it could be an epithelioid sarcoma, synovial sarcoma, or undifferentiated pleomorphic sarcoma. So those are scary, but they're not super common, but you always have to rule those out. So what tests and exam would you do specifically for maybe this one? So we already talked about, is it mobile, right? And what do you see versus with a ganglion cyst or a lipoma versus like a epithelioid sarcoma? What would be the difference between those two on the exam?
The lipoma is going to be movable.
Very movable, right?
Very definitely.
Soft or hard?
Soft.
Soft initially, but the longer it's
But it can
there,
be
it
a little harder.
can harden.
Yeah.
Okay. So mobile versus fixed. Going back to that pseudoaneurysm, which is pulsatile. So notice the location of this pseudoaneurysm. Does this look any similar to Our Lady that we saw at the very beginning, that 52-year-old? Right? It's volar. It's right on that radial aspect, which is hers where hers is. So the big concern there is that mass, is it pulsatile? Can you feel it and feel the thrill of the artery, right? So this is an example right here of what that looks like. And here you can see right off the radius, there's the radial artery, and then that's that pseudoaneurysm. So hard versus soft, we talked about that location, right? So if it's going to be by the radial artery, more common there. Ganglion cysts, where are those usually?
Sure.
Yep, on the dorsal aspect of the hand and on the volar aspect of the wrist, right by the radial artery. We'll talk about that location here in a little bit. Okay, what if it was on the dorsal aspect of a finger? What would you see there with that wrist mass or hand mass? So we call that a retinacular cyst, which is the same thing as a ganglion, right? Or a Bouchard nodule, Heberden's nodule. Those are just associated with arthritis. And then what's the involvement? Does this involve more layers than just one area? Is it involving skin? Is it involving muscle? Is it involving tendon? Right? Because then you worry about a little bit more invasive growth, right? Because it's involving multiple tissues.
Lipoma can do that.
Lipoma,
It can be very movable. It can actually be a little more invasive.
yeah. It can be, the key thing there is making sure it's not a liposarcoma versus a larcoma or versus a lipoma. Lipoma is going to be fairly specific to the fat layers. It rarely will breach the fascia, but a liposarcoma will breach fascia. So that's kind of the key thing differentiating from that. So one of the main tests is what we call transillumination. So transillumination test is being able to tell if this is hard or filled versus a cyst filled. So you simply get a pen light, or honestly, I use this with my cell phone light, turn the lights off and put your cell phone right by there, and you can see really well how it will transilluminate the cyst and the area around it. I don't know if you can see it very well from there, but if it transilluminates, the data suggests that it's 75% chance it's a ganglion cyst. But if surgeons do it, I don't know why the difference, probably because the surgeon wrote this article, it's 97%. So apparently we think we're better with a pen light than anyone else, which doesn't make sense. But so again, transillumination is a great way to be able to see, real simply, is this a cyst-filled mass or is it hardened? So talking about ganglion cysts here, it's more common dorsal than volar, but those are the two main locations that you'll see: the dorsal aspect of the wrist between the third and the fourth compartment, right at the kind of scapholunate junction. I'll show a picture that helps show that. What happens is just a weakening of the capsule, or a weakening of the ligament that surrounds that joint. And just like you see a bicycle tire, and the bicycle tire gets a little damage to it, you'll see that outpouching of the rubber, that if air fills that area and just kind of balloons out. And then the way this works is it has a one-way valve. When the fluid gets pushed into that sac, it doesn't get back. So it's literally like blowing up a balloon, just like you'd be able to, every time between every breath you hold that, it's got that one-way valve. And then over time, the cyst the fluid will kind of dehydrate or get resorbed, but the proteinaceous portion stays. And over time, that proteinaceous portion turns jelly-filled. So literally, when you remove these, it's like squeezing jelly out of a little ball. The other thing about ganglion cysts that helps is when you're going back to that history is saying, hey, how long has this been there? And is it growing? Is it getting worse? And frequently they'll tell you it will fluctuate. It'll get worse and then it'll go away and it'll get better and then it'll come back. And then you ask them what causes it and they say they don't know. And that's pretty typical. So anything that fluctuates in size is usually not cancerous unless it's fluctuating the wrong direction and just going up, right? But if it fluctuates, it's better. So when looking at ganglion cysts, this is kind of an article that came out in 2020 that looked at kind of wrist masses and best ways to kind of determine if it's a ganglion cyst versus anything else that's concerning. First thing they talk about obviously is a dorsal wrist mass, but I would argue volar wrist mass should also consider that as well. And then the atypical features are things that you should be worried that this is not a ganglion cyst. So the typical thing is to see a wrist mass and your first diagnosis is ganglion cyst. The article, and I agree with this, discusses that realistically it should be the opposite. We should rule in that this is a ganglion cyst, not rule out that it's other things. So basically prove that it's not ganglion cyst first. So looking for atypical features, ulnar-sided on the volar aspect or the dorsal aspect. If the symptoms have been less than 6 months, if there's growth that's rapid and it doesn't fluctuate, if any of that's positive, then consider an MRI just to make sure that it's not a ganglion cyst and rule it out. Do you have to have an MRI for every ganglion cyst? No, absolutely not, okay? Now, I think the whole point of this article was more of a, let's just make sure it's not a ganglion cyst, because what you don't want to do is get in there, try to remove a ganglion cyst, and it's a sarcoma. You've now breached tissue lines, you've now created an issue that may cause an amputation in that person's hand. So it's really kind of not worth messing. But if it's pretty straightforward, you know your diagnosis, you go through those criteria. We talked about you can do a transillumination test. If it's negative, then I would go towards an MRI and rule out that it's not anything else. If it transilluminates, it doesn't have any atypical features, it looks like a duck, smells like a duck, quacks like a duck, it's probably a duck, right? And then you can aspirate it. Again, the downside with aspirating, if you're not 100% sure, is what if it's not a ganglion cyst and then you've just punctured a cancerous tumor, right? So when in doubt, an MRI is a good thing, especially if you don't feel comfortable with it. But again, if your diagnosis is good, you understand the principles, you don't have to worry about it. Sensitivity versus specificity is 94%, so it's actually fairly high with an MRI. So on MRI, what you'll see is you'll see a multilobulated fluid-filled area. So specifically for our patient, you can see it's on the volar aspect. Here you can see the radius, you can see the ulna, you can see the radial artery up in this area, and then you see this multilobulated area. So for her, the radial artery was sitting right on top of this. So we did get an MRI because it was pulsatile in one specific spot. So I had to rule out that it was a pseudoaneurysm. It was not a pseudoaneurysm, but the radial artery was being compromised, and so the flow was being pushed pretty hard, and you can feel it pretty palpably. Any other tests as you're considering that this is a ganglion cyst, and as far as what you want to do to consider outcomes, functions, if you're going to remove this, anything else that's very important as you're around the radial artery, anything like that?
You want to know what the primary blood supplies they have.
Great.
Ulnar or radial.
How do you do that?
Allen's test, I think it was.
Man, I'm setting you up for success. This is perfect, right? It's exactly right. So the most important thing is I need to know if I'm going in there to take out this ganglion cell or ganglion cyst, what happens if I accidentally get the radial artery? Because it's all the way around it. In fact, some of the lobules are actually grown over top of it. What happens if I cut that artery? What happens to the hand, right? So you do an Allen's test, which is basically this modified Allen's test. You compress both radial and ulnar artery, have them squeeze their hand 6 to 10 times, and then as you do this, release the radial artery and see what kind of flow it takes. So for her, it was a 3-second return. So once you do that, compress them again, and then let go of the ulnar side, and then see what that is. For her, it was less than 1 second return. So she is ulnar primarily, which is the vast majority of our hand is supplied by the ulnar artery. So doing an Allen's test will just kind of let you know what to expect. So for her, majority of her blood supply was on the ulnar side. So that when I counsel the patient, I say, great, I'm going to try not to cut your radial artery, but if I do, you'll be fine. And that's just kind of good to know. But obviously, if you do, you try to repair it, but you never really know. So you just want to make sure that you know where the blood supply is primarily coming from. So treatment options for a ganglion cyst. So first thing you can do is observation. So one specific study talked about 42% of these, if you leave them alone, can resolve on their own. So spontaneous resolution is what they call it. It'll just kind of go away. And we talked about that fluctuating portion. Basically, that fluctuating will happen when that one-way valve either gets stuck open, and then you get an equilibration between the joint surface and the cyst, and to where it actually can completely decompress. It often doesn't. It often will equilibrate to where the pressures are the same on both sides, and usually that means it's just a little bit smaller. But most of the time, these resolve. Bible, you can pray it away.
You whack it away.
No, you actually, it's not praying it away, it's actually hitting it with the Bible. It does work. We don't recommend that, but that used to be the old adage, and that's why they're called Bible cysts, is they would actually, and I actually found a couple videos I couldn't put on there because it had the guy's copyright, but it was showing this guy who frequently takes just big books and he breaks them and pops them, and then he shows the swelling afterwards, and I don't know why he shows that because it doesn't look very appealing. But yeah, that's what they used to do. They used to hit it with the Bible, and that would make it go away. And it basically just rupturing the capsule of the cyst and having it go away. Splinting, why would splinting help with the cyst? Would that make it go away? What do you think? Any hand therapists that are here?
I'm thinking compression or just immobilizing that joint, stop irritating it.
Yeah, because remember, it's caused by motion and pressure being pushed in within the joint. As you relax the wrist and relax the joint, it's gonna, as you're not bending it and not moving it, it's not putting pressure into that, past that valve and putting it into the joint, right? So the theory is that simply by splinting it, we'll see it reduce. It's not super common. Most people don't do that because you're fighting with stiffness versus mobility. They come to you with a mass and they walk out with a cast. That's not really fun. They don't really want that. It doesn't really work as well. And the other one to think about is aspiration. Can you pull the fluid out? No, it's a little bit more difficult of an aspiration because it's not just fluid filled, it's jelly filled. And so it's often, people will use a 15 or 25 gauge, something really small, and you're not pulling anything in that 25 gauge. In order to aspirate it, you have to use at least an 18, which is a large needle, into potentially a very small mass, and so you've got to get it just right. They show that ultrasound aspiration is a lot more effective, like twice as effective. So if you have an ultrasound, you feel pretty facile with it, and you want to aspirate it, you can. But it's, as you see the data there, potentially 13 to 85% effective. That's horrible data. I don't even know why they published that, but they kind of should. But realistically, they see a 73% recurrence, and that makes sense, right? We haven't fixed the problem. We haven't fixed the valve. We're still dealing with the same issues. And then, of course, surgical excision. And even then, it's still anywhere between 10 to 20% of recurrence afterwards. And we'll talk about why that is. So another example of a Bible cyst. So this is actually an old ad that I found, that if you had a Bible cyst, that you could come to this guy and he would get it away with his Bible. I don't know. I thought it was hilarious. I had to put that. So this is an example of what a dorsal wrist ganglion will look like. You see that little small stalk that develops from the base of the scapholunate area. And it's just a little bit of a rent in the capsule, a rent in that dorsal ligament, and it just creates this little valve and it creates a stalk. The reason why it's a little stalk is because there's not much room right off the immediately after the capsule and the ligament. So the stalk kind of finds its way, and eventually once there's more room, which is usually between that third and fourth dorsal compartment, it finds that little spot, and that's where that cyst usually develops because of that weakness in that extensor retinaculum. So here the example they're showing here is doing a scope to remove it, but realistically this is the same idea with aspirating. The more you can get at the stalk, and actually we'll see some people when they aspirate, once they aspirate and get into the stalk, will actually just start doing kind of a dry needling puncture, trying to just create a secondary area where the fluid could dissipate, and that helps with reducing the recurrence. So this is what it looks like with a surgical excision. You can see the big cyst, which multilobulated. You can see almost the yellow coloring, which is that proteinaceous mucin that sits within the cyst. Then you'll see the stalk going all the way down to where that carpal bone is. And that's kind of the key thing about the surgical excision is when you're doing that surgical excision. This is an example of a hand surgeon that in New York that does it. He kind of describes it as an inverse pyramid. As you're dissecting it, you're starting wide at the top, grabbing the cyst, and then you kind of want to funnel down to where the bottom is, where the stalk is. Once you get down to the stalk, you don't just clip it. You actually want to burn a hole right at the base so that there's a bigger opening, so it's not going to recreate a one-way valve. It's going to be a complete communication between the inside and the outside. So this is our lady. You can see on the left there. I'll stand over here. See on the left here, I've got the radial artery dissected out, got a vessel loop around it, and you can see right there's a radial artery. See how it's white right here? That's why it was pulsatile, is it was actually had a lot of pressure pushing up against that artery and very difficult to get blood flow. So all of her blood flow was coming from the ulnar over time. It actually had very little coming from the radial aspect, which is why it took 3 seconds or more to return. You can see the multilobulated nature of that cyst right there. And then of course right here is after we removed it. You can see the FCR tendon. You can see our radial artery back to where it needs to be. And then right here is actually the tip of the scaphoid. So you can see we dissected all the way down to the scaphoid, and right there is that scaphoid and radial scaphoid junction. So when you guys get these and after we resect these, what's our postoperative protocol? What do you guys usually see for those that treat ganglion cysts as far as immediate postoperative evaluation and monitoring? Okay, so obviously the big thing we always talk about in orthopedics is movement versus not having movement. So the downsides of splinting is going to be obviously stiffness immediately afterwards. They talk about resolution or chance of recurrence if you're moving it right away. But if you've done a good job with the stalk, the data suggests that you don't actually have to splint. And so the recommendations is for not splinting, actually completely letting it move. So we'll usually just close it on the inside, put some dermabond glue on the outside, 4x4 cast padding and a simple A-strap, and then that's it. And we actually have them start moving right away. So you want immediate range of motion because there's no reason for these to be splinted. And the data suggests that the recurrence rate does not matter based off of that, based off of new data. And so immediate motion is key for these, specifically working on supination, flexion extension of the wrist. And then from an activity standpoint, usually we have them wait about 4 to 6 weeks before they start doing any push-ups. If it's a dorsal on the volar aspect, same thing, just because you don't want to stress that ligament and capsule because you were just in that area. Give it some time for that soft tissue to heal, and it does better. So in summary, the key thing about that article that we talked about, which is that DS et al. Article, that review, was just to consider that these cysts, yes, they are very common and it's very simple, and we talked about one very straightforward case today, but the key thing is not assuming that it's always a ganglion cyst, because you can get yourself into real trouble, especially if you're going to start aspirating. So really work on your differential diagnosis and definitively diagnose it before you decide to do any invasive procedures. When in doubt, get an MRI. I know that's not usually the best things we talk about, just throwing it at an MRI, but when it comes to masses, man, it's so much more important to rule it out before anything else. And then the last thing is really talking about the options and counseling with them, because again, the recurrence rate with certain things is higher. So I have a lot of patients who just simply come in for their first consult and they'll say, hey, just aspirate it. Great, happy to do that. Let me just let you know what to expect here. So we're going to poke a hole in it, and there's a chance that it could recur about 73% of the time. Versus surgical excision, hey, we're going to cut this out, and if I do a good job with the stalk, it shouldn't come back, but there's still a 10 to 20% chance of recurrence because we didn't fix the problem, which is a rent in the capsule or a tear in their dorsal scapholudate ligament. So just really talking with them about the recurrence. Now, I went back and looked at my data. I've had no recurrences yet, but I also left Texas and have no idea how those patients are doing. So it's really easy to say, right? Follow up ruins surgical outcomes, right? That's exactly right. So, any questions about wrist masses, dorsal ganglions, volar ganglion cysts? Again, a topic that I know we just don't talk about here too much is hand masses. Just thought we'd bring up this interesting case. Gary?
Just more of a comment. I think getting an MRI before you try to, aspirate or put a needle or anything is like super, super, super critical. So you can go from, excising a little mass because you think you know what it is to like an arm amputation if you, expose fibrosarcoma to an entire forearm compartment, which I saw a couple of times in my residency. So super critical to get the appropriate imaging, X-ray, MRI, and then unless it's totally clear that this is a small little ganglion or whatever, and it has completely benign features on MRI, then I think you're okay to kind of go through the treatment methods. But if there's any question, it's send it up to one of the ortho-oncologists up there to take a look at it, because you can't. That's a mistake you just can never make. So that's all.
And there's not much room for failure as you're dealing with that location, because there's not much tissue there. So if you breach a surgical plane in the wrong way, or you hit it with the Bible and you've now broken the sarcoma within the different tissue planes, it's not ideal. You really are potentially looking at a wide resection, which is an amputation of that arm.
So I was just thinking about this because I think in our practice we run into patients who have these. I've probably seen 3 or 4 for the past maybe 5 or 6 years, and I think we're fighting the lay perspective, which is like, oh, it's just a Bible cyst, or oh, just go get it drained, like just those things because they get any advice from their friends and their neighbors, and I didn't know the data on sarcomas. Like that already making me change my perspective. Like, hey, maybe you should actually just get this looked at and just don't let somebody drain it. Because I think before it was like, oh yeah, just people drain it. I mean, I knew the recurrence rate. I knew that draining it really wasn't that effective. But I think it's actually good for us to think about this at this level, because we're going to see these patients, and now, at least my perspective's changed. I think that's probably what these meetings are for, right?
Yeah. Again, this isn't a talk to say that, ooh, everything's cancer, right? But it's just as a way for us to step back and really just think about our differential and say, likelihood, right? 59 to 65% of wrist masses are usually ganglion cysts, right? Or in the hand specifically, we talk about hand nodules as well. That's like 50% are retinacular, Bouchard nodules, which is osteoarthritis related. So it's typical, it's common. But the problem is you get that one, and like Gary said, in his career, he's seen one. So guess what every time he sees a cyst, he's gonna do? He's gonna get an MRI, right? Because that's guided his practice to say, I never want that to be me, that I was the person that caused this issue, right?
Can I alter?
Sure, go ahead.
I've never seen one.
I've
never seen a sarcoma. What I thought was a ganglion cyst has always been, as far as I know, it's always been a ganglion cyst throughout my entire career.
Yep. So do you get an MRI, in your practice, would you get it?
Before MRIs were common.
Oh, don't age yourself. Come on, that's not true. Now, so again, I think our exactly, and that's the point exactly, is that your practice is based off of what you've seen, right, and what we've experienced. And for those of us who've seen a lot of ganglion cysts, and I've seen a whole heck ton. I mean, that's mostly what I see when I see a wrist mass sent to me. But the key thing is you can't get lax in your diagnosis, right, and thinking about it, because all it takes is one epithelioid sarcoma or one melanoma that actually is grown deeper than just typical superficial discoloration. That's all it takes, and then you're dealing with someone that's going to have some life-changing issues as they lose that hand. Right. So again, not to scare, but just to make you think about the differential, make you think about those things, the different tests that you can do to help kind of dissuade that patient. So they do come in, you're like, I think this is ganglion. Let me do a transillumination test. Okay, it transilluminates. The chance of this being a ganglion cyst is like 60 to 70%. 97% of your surgeon. No, I'm just joking. I don't know where that came from. Anyone can shine a light at it. My daughter's going to do that, right? So the point is just understanding how you can assess it and how you can diagnose it.
You didn't comment too much about ultrasound. It seems like ultrasound
Great.
is a great tool to differentiate between a tumor and a...
You're exactly right. So an ultrasound's a very great way. I didn't have any of my own ultrasound just because we didn't on this lady. I got an MRI just because of the location. I wanted to make sure that it wasn't a pseudotumor because it was pulsatile. But you're exactly right. Ultrasound, for those who have ultrasound, it's excellent. It's a great opportunity to look if it's a fluid filled or if it's hard mass.
You can do it in the office.
Yep. It's cheap, it doesn't cost you anything. You can actually bill for it because you ultrasound, so it actually benefits your practice, but it's a really good way to help diagnose a little bit quicker and easier. So that's very, very good. Just like I talked about with ultrasound aspiration. If you're gonna aspirate it because you've got a definitive diagnosis, it's a great way to do it. It's a great option. So anyways, things to think about. Thank you.